we're really happy to have you, Dr. Carethers, with us. Is with us today, and is someone that I have not only the utmost scientific respect for, but as an administrator, particularly of one of the country's best internal medicine programs in the country, which at University of Michigan. Again, I know how hard that task is, and you've been making lots of impact in the context of the field. So let me just start off by letting everyone know that he is completed his residency at Mass General in Boston. That was followed by a GI fellowship at the University of Michigan. After establishing himself there, he wound up becoming, working his way up and also becoming the division chief, which he did a wonderful job out at UCSD. And for those of you who don't know the UC system, is UC San Diego, and that program since his arrival there and departure has really never been the same. It's been an outstanding program. He built that, and in fact, he left that program in an outstanding situation where even today, I think his past work still has is felt throughout the UCSD system. After UCSD being the division chief, his work certainly went noticed. And he became the chair of medicine at University of Michigan in Ann Arbor, Go Blue, in 2009. John has had a long history and distinguished history of research and in particular, his efforts in and around GI focused work around familial adenomatous polyposis, of which he has a number of papers. He's been continually funded, and in fact, his publication record is outstanding. As a result of that, he wouldn't tell you, but I'm going to tell you because he usually doesn't. There are many people who, when they get into the National Academy of Medicine, you sort of say, well, they're smart. Well, sometimes there's not the complete package. John, upon his selection and induction into the National Academy of Medicine, was really what I consider to be the model for what we consider the best and the brightest in the United States. And to be honest with you, I am and proud to know him. He's going to talk a little bit more about his research. And again, I'm going to brag on him just a little bit more, but I know we got to get things started. He joined the American Gastroenterology Association Governing Board in 2020 and as a vice president. And I believe you will be taking over as the president-elect in 2022. Is that correct?
President-elect in 2021 and president in 2022.
22. So thank you for that. And you may be wondering why he is here today for this grand round, which I am completely excited about. I think that when all of us have been going through this COVID period, and many of us have been trying to put together the pieces. And I think the presentation that John will give to you today is probably the most thorough, thoughtful, and provocative talks that we actually have around COVID and what we've been going through from a scientific sort of perspective and putting all the pieces together. So without further ado, Dr. Carethers, I'm going to turn it over to you and to give your talk today. Thank you.
Thank you.
I want to say thank you, Patricia Syme, also, real quick. When we talk about partners in crimes, this could not have happened with another chair that I love a lot, which is Dr. Patricia Syme, our fearless leader of our internal medicine department. And so us co-branding this together, I think, was really important. And so thank you, Dr. Syme and the Department of Medicine.
Well, thank you, Rob, and thank you, Patricia, for having me today. I wish we were there in person, but during the COVID, we have to be apart a little bit. So I've known Rob for a few years, and thank you for that wonderful introduction and your work in cancer disparities. Your work is not going unnoticed as well, Rob. So thank you for that. I'm going to do a little different. I actually work in the field of colorectal cancer. But I do touch on disparities in that field. And probably back in May or June, the American Association of Cancer Research asked me to put together something on COVID-19 and disparities. And I said, well, there's not much known. First of all, COVID-19 is relatively new. Some of the early data that came out in regards to disparities wasn't there. And it wasn't until several months into the pandemic that some of the data started coming out, and that was after some of the outcry from cities like New York and Detroit and other places where the virus was wreaking its havoc at the time. So as part of putting that talk together, I've since added more information, and actually I drafted a manuscript of this in summary, and it's under review right now. So I'm going to go through what I put together and see what you think of it. So I'll go ahead and start. I have no specific disclosures other than NIH funding and funding from the University of Michigan. So we all know that COVID-19 is a new severe, by the way, can you see the slides? I just want to make sure. Can someone just mention that they can see the slides?
Yes, slides are seen.
Perfect. Okay. So we do know that COVID-19 is a new severe, principally pulmonary, but also vascular disease caused by the SARS-CoV-2 virus. The virus utilizes the ACE2 receptor to infect cells and gain entry, triggering pneumonitis and potentially a severe cytokine storm that can really cause severe disease. The virus has its principal tropism in the lungs, we know that. However, the virus can infect any cell that can express the ACE2 receptor, including the liver and heart and kidneys. We also know that vascular endotheliitis appears to be more severe with COVID-19 as compared to another pneumonitis, influenza, or even non-specific interstitial pneumonitis. And that is shown here on this right graph, showing what they call angiogenic features. And you can see that COVID-19 has many more angiogenic features, i.e. damage, than influenza or non-specific interstitial pneumonia. So this creates essentially another unique difference in driving this disease. I will also point out in this tropism study that was recently published in the New Journal of Medicine that many patients seen in this purple shows that many have severe comorbidities that may affect viral infection. So there have been 4, I'll say, major identified risk factors that put a person at higher risk for COVID-19. The older a person is, the higher the risk. The presence of health comorbidities, including obesity and diabetes, cardiovascular disease, high blood pressure, asthma, and chronic kidney disease, place one at higher risk for COVID-19. And in particular in the United States, and there's some data out of the UK as well, specific races and ethnicities in the United States, particularly African Americans and Native Americans, appear to be risk factors. And also, male gender has emerged as a risk factor as well. And I will touch base on all 4 of these, particularly on any science that's driving their risk. So first, age and comorbidities. Now, I need to update this slide because now we have over 7 million documented cases of COVID-19, which is the highest number of cases in the world. And while the average age of all cases is in the mid-40s, and you could argue that that is slowly trending toward the 30s with a number of young people getting the disease, the majority of infections, of the majority of infections, 62% of the infections occur in those under age 50. And I'm telling you that because when we talk about deaths, that's different. So 62% of all the cases from the CDC website are under the age of 50 to date. And that number is probably slowly increasing with younger infections going on. As alluded to, children are a growing recognized reservoir of the virus, which has been recognized over time during this pandemic. Black and Latinx children make up the bulk of this reservoir. Okay, so it's really disproportionate on the children. Even though they may not be getting as sick as adults per se, they're making a big portion of this reservoir. Some children may get sick with a multisystemic a multi-system inflammatory disease of children called MIS-C. And there's been a couple of papers already published in the New England Journal of Medicine about this. They manifest dermatologic, gastroenterologic, and nephrologic and cardiac disease, likely from the combination of the virus infection itself in those cells, because they contain ACE2 receptors, in combination with a massive cytokine or cytokine storm release. Now, deaths from COVID-19 are more likely in older populations, with increasing mortality with each older decade of life shown here. You can see this is data from April when the northern states were hit with their surge. The highest peaks are those over 85, and you can see each decade of life is slightly lower. Those are the ones who are really dying from this disease. And indeed, 95% of the deaths occur in people over the age of 50. So 62% of infections under the age of 50, 95% of the deaths over the age of 50. The CDC has posted several conditions that place a person at higher risk for COVID-19, including chronic kidney disease, COPD, those who are immunocompromised, including those who are getting active treatment for cancer, obesity, cardiovascular disease, sickle cell, and diabetes. Other conditions are listed on their site as might be at increased risk. Interestingly, a knowledge-based network of COVID-19 morbidities show association with high blood pressure, chronic kidney disease, cardiovascular disease, pulmonary disease, and autoimmune disease. And this network also shows the congruence of expressed genes. These were patients who had COVID-19. And notice that IL-6 comes out, VEGF-A, think of, so IL-6, think cytokine storm, VEGF-A, think of endotheliolitis, and look at ACE2 receptors all came out, which is the attachment for the bug. So what do we know? The best data on age and comorbidities to date for COVID-19 come from studies actually in skilled nursing facilities. In this particular study published in the New England Journal of Medicine, COVID-19 spread rapidly from residents and healthcare workers at the skilled nursing facility. And you can see this happened over literally a 2-week period. The average age of residents was 83 years old, with most of them having at least one or more comorbid conditions. So 2/3 had hypertension, 2/3 had cardiac disease, nearly half had renal disease, 1/3 had diabetes, 1/3 had obesity, etc. So is it the age or the comorbidities here? If you look at those who are in healthcare personnel or those who are visitors, you notice their age were younger, but the number of comorbidities is much less between the visitors and healthcare personnel as compared to residents. Unfortunately, it was largely these elderly patients, these 83-year-olds with these comorbidities, who largely died in these nursing homes when this surge happened. This is data from Seattle, Washington, and it was not the healthcare personnel or the visitors that principally died. In another study, also from a different Seattle skilled nursing facility, residents who became virus positive had higher rates of lung and cardiovascular disease, stroke, and cognitive impairment. And that's shown here. You see, this was a study done somewhat prospectively in a nursing home in comparing people who tested positive for SARS-CoV-2 and negative. And notice that those who tested positive for SARS-CoV-2 were 5 years older, more likely to have chronic lung disease, cardiovascular disease, a CVA, and cognitive impairment. The most fascinating thing about this study, again, done prospectively, and look at these, the red circles. These are people who develop positive cultures of the virus anywhere from 0 to 7 days before having any symptoms, okay? And you see a handful develop positive cultures after they've developed symptoms. So this was one of the first studies showing the pre-symptomatic or asymptomatic spread of the virus before it even got symptoms, okay? And in a nursing home where you have older people with a lot of comorbidities, this is absolutely a recipe for disaster, for spread. So overall, data for age and comorbidities as risk factors for COVID-19 comes from these studies at skilled nursing facilities. The elderly population combined with health comorbidities show weakened immunity that place them at higher risk for severe disease and mortality. In addition to the issue of age and comorbidities, skilled nursing facilities, unlike hospitals, accentuated the age and comorbidity disparity due to the lack of ability to isolate patients, particularly infected patients, or even, of course, there was the asymptomatic and pre-symptomatic spread of this. There was a lack of viral testing. There wasn't even that in acute hospitals. And probably even the most important thing, where hospitals were short of PPE, nursing homes had no personalized protective equipment that could protect anyone else in the nursing home, particularly early on in this pandemic, from infection. So so that's age and comorbidities, and it's very tough to tease out the difference between, is it the age driving the risk or is it the comorbidity? And I'll say it might be both, but I'll tell you as we go through this grand rounds that comorbidities seem to keep coming up every single time, and it may be the bigger driver. So I'm gonna accentuate that with the potential insights into race and ethnicity in COVID-19. So first, a little bit of epidemiology. The distribution of COVID-19 cases vary by race and ethnicity, as we know, with higher rates for African Americans and Hispanics compared to their population proportion in the United States. Shown here, Hispanics make up 17–18% of the population, but they're infected 32% of the COVID-19 cases. Blacks make up about 12–13% of the US population, but they were over 20% of the cases. Whites make up 60% of the population, but they were only 39% of the cases. I even looked at my own state of Michigan. I didn't specifically look up Virginia, but in my own state of Michigan, the proportion of Black population is around 15% in the state of Michigan. But they were 37% of the cases, 42% of the deaths. Okay, so great disparity based on, and so what's driving this? So the disparity for COVID-19 deaths is predominantly for Black and Latinx patients, as well as Native American patients, which I'm not showing specifically here. So I'm highlighting this recently published paper on the mortality data, particularly in the United States for every state in the nation. My own state of Michigan, for Blacks compared to whites, was 7.45 times more likely for deaths from COVID-19. Latinos was about on par, was 1, okay? But if you look at the entire United States, that was almost 3.5 to 4 times more likely in a Black and 1.88 times more likely in someone of a Latinx background. So there is disproportionate, although there's variations between these two groups that I show. If you examine COVID-19 deaths by race and ethnicity, the rates by race and ethnicity, African Americans have the highest death rate overall. And that may be surpassed by indigenous population based on some of the data, although that is somewhat come down in the Southwest United States. As you can see here, the deaths per 100,000 in data taken about a month ago from the COVID tracking website shows 78 per 100,000 for those who are African American, 44 and 43 per 100,000 for Hispanics and Native Americans, while it's 32 per 100,000 for whites. And if you do the adjustments with whites as the standard, if you're African American, you were 3.7 times more likely to die indigenous 3.5 times more likely to die, etc. So this shows that the rates are markedly different from COVID-19. If you look at that by age group, there was no difference there either. So whether you're young, even though the number of deaths are lower in the younger age group, they still peaked, shown here in the dark blue, for African Americans, and the second highest was Hispanics and even some Asian groups there. If you look at this compared using whites as 1.0 standard, again, even in the rare instance of death in younger age groups, blacks in the 25 to 34 were 6.5 more times likely to die from COVID-19 than a white person, and Hispanics were 4.5 times more likely. The numbers get smaller as we get older because it's the older age groups and those comorbidities in which that affects no matter what your background is. Now, the real question is it race or something else driving this? And this is data taken from a preprint server. The last time I checked, which was about 2 weeks ago, it hadn't been accepted in another form, so this is not reviewed. But this highlights the social and epidemiologic risk factors for COVID-19 death. So people with medical disabilities, okay, grocery store mobility. So this means grocery store deserts. So anything to the right of this line is a worse thing for COVID-19 death, and anything to the left of this line is better, a lower rate of death. So it didn't matter if you were black or male or white, and as long as you had insurance, you were less likely to die of COVID-19 than someone without insurance. And look at this, parks mobility. You live near a park, meaning you lived in a higher rent district, if you will, you were less likely to die from COVID-19 than someone who lived in a grocery store desert. And irrespective of your race or gender, as long as you were in poverty, you were more likely to die from COVID-19, okay? So I note again that African Americans and Latinos had the highest infection rate and the highest death rates, okay? But they're also the hardest hit economically before as well as after COVID-19. So look at these questions here. What percent, this is the percent saying that someone in their household had lost a job or taken a pay cut due to the coronavirus risk. So for Hispanics, that jumped from March to April to 61%, for blacks 44%, and 38% for white. What about the percent after the virus was in the middle of the pandemic that they do not have rainy day funds to cover any expenses for up to 3 months? It was 47% for whites, but over 70% for blacks and Latinos, meaning that they are going to be hit economically hard. Not only the effects of the virus and more likely to die from the virus, but economically hit hard as a result of the virus, whether they were infected or not, okay? So what are the things that could be driving this? This is data from another preprint server, and again, I checked about 2 weeks ago. It hasn't been on a peer-reviewed site yet, but so I expect it to be. But sorry, this data looks at the average relative vulnerability index or the distribution of comorbidities. And so they break it down into age 25 to 44, 45 to 64, and 65 plus. Excuse me. And you can see that even in middle age, 45, 64, that blacks tend to have a higher vulnerability index, i.e. more comorbidities than whites or Hispanics. And that carries true in those who are Medicare eligible, right? If you break this down by the number of risk factors or the number of comorbidities, you see orange is 1 risk factor. So blue is 0, orange is 1, gray is 2 risk factors, and the yellow is 3+ risk factors. Even in those age 45 to 64, you can see similar between non-Hispanic whites and Hispanics breakdown for those risk factors. Blacks already had higher 3, 2 risk factors compared to whites and Hispanics. That's even grown wider, and those are 65 plus. So there tends to be much more comorbidities in Blacks as they age. It was largely in large U.S. metropolitan areas where they have high proportion of African Americans that were hospitalized. So this little insert here is shows the proportion of positive COVID-19 tests on the y-axis and the proportion of Black individuals in care. And you can see this is by cities, and you see big cities with large African American populations pop out. New York, New Jersey, New York and the Bronx, New Orleans, Detroit, Chicago, Philadelphia, Washington, D.C., okay? So they pop out when you analyze the data this way. Now, the data I'm going to show you on this New England Journal of Medicine article is data reviewing the experience from New Orleans. So if you look at this data, this is comparing hospitalization versus in-hospital death. So they had models. And their models were pretty sound, and I'll show you why I think they're sound. If you were Black compared to white, no matter which model, you were about twice as likely to get hospitalized with COVID-19. And obviously, if you were older, in two of them, this is not in model one, but in two of their models, you were more likely, about 30% more likely to get hospitalized. If you were female, and I'm going to talk about gender a little later, you were half as likely to get hospitalized. Okay, irrespective of your race. If you lived in a low resident income area, you were 22% more likely to get hospitalized. And if you had Medicare or Medicaid, you were 60 to 70% more likely to get hospitalized versus those who had commercial insurance. Okay, and if you were obese, you were 43%. So again, this shows you that the comorbidities might be driving this. Now, the fascinating thing is what happens once you got into the hospital. Now, I stress this is an academic medical center. Once you were in the hospital, whether you were Black or white, on all their models, you were just as even to die from COVID-19 as if you were African American compared to a white patient. So this tells you, at least if you get good medical care, once you're in the hospital, your risk is the same, irrespective of your race. Again, if you were older, you were about 20% more likely to die. Okay, if you were female, you were 35% less likely to die. And I think the data is sound because if you had high respiratory rate, you were twice as likely to die. If you had a low absolute lymphocyte count or platelet count or high creatinine, you were elevated level to die, high venous lactate, and high inflammatory markers. So the bottom line is, based on this data, more African Americans were likely to be hospitalized, but once you were hospitalized, you had similar death rates. And I don't show you the data, but there's paper looking at Black United Kingdom patients, and it was very similar data, okay? And there was another paper that was just published about 3 weeks ago in JAMA Network Open. They had very similar data. Again, I stress these are larger academic centers. And the risk increases with the risk of comorbidities and lower socioeconomic status, but it decreased with female gender. So based on that data, this is the way I think of this disease. I think that we start out based on our system in the United States and in other areas as well, that it's all about systemic socioeconomic inequality which drives your socioeconomic status. You tend to attain lower levels of education and difficult access to healthcare. And then that has long-term, lifelong downstream consequences. It determines where you live, determines the types of jobs you're eligible for and can get, determines how many jobs you work in. It determines, again, where you live, if you have good veggies and fruits, and poor access and affordability of healthy foods. It might determine the diet you're on. If you live near party stores and things that don't have healthy diets, you tend to eat more high-fat, high-caloric, low-fiber diets. You have also increased access to alcohol and tobacco, maybe low physical activity without parks being nearby, etc. And you're more dependent on qualified health centers and other versus just insurability for routine preventive health care. That ultimately has physiologic consequences in your own body. Your gut microbiome is going to change. Your lung microbiome is going to change. Your skin microbiome is going to change. You're going to have increased localized inflammation because of the changes in the microbiome. And you may have some level of compromised immunity. And those things are what drives the lifelong development of cancer and obesity and diabetes, etc. And it turns out those are the exact high risk factors for COVID-19. And so they are actually the same because of this the way our system is structured in the way we develop economics in this United States of America. So let me look at some other aspects of how race might be involved. So the question came up of the use of ACE inhibitors for people with hypertension, cardiovascular, and kidney disease. And we know, if you look at the United States, and this is taken directly from the CDC website, that about 40% of African Americans have essential hypertension, compared to about 25, 28% of other races and ethnicities in the United States. Now, there's a lot of ways. So first you have to recognize the hypertension, but there's a lot of ways to treat it. But one of the ways that has been treated, and some of the subsequent damage from hypertension, i.e. kidney failure, heart failure, is to use ACE inhibitors and ARBs, okay? And we know all these. And so the question came up, could this cause a disparity? Because it turns out there is some early, at least plausible theoretical data that the use of ACE inhibitors and ARBs might get a secondary increase in the ACE2 receptor, which is the binding site for the SARS-CoV-2 virus. So the question is there a secondary increase in expression of ACE2 with the use of ACE inhibitors or ARBs? And will persons treated with ACE inhibitor or ARBs be more susceptible to COVID-19? And could that drive a disparity? The answer is a resounding no, at least nothing to date. There's been at least 2 studies and probably more studies popping out now showing data that that is not the case. This is a study published in the New England Journal of Medicine looking at the odds ratio of using ACE and ARBs on the risk for COVID-19. And as you can see in their adjusted data, it's essentially 1, meaning there's no preponderance of risk. And is this data sound? Well, if you look at people using loop diuretics, think heart failure, their risk was 46% higher. People on insulin, think diabetes, their risk was 37% higher. People on antiplatelet drugs, think CVAs and heart disease, 19% higher. People on drugs for respiratory disease or immunosuppressive agents, 25 to 30% higher, or if you had active respiratory disease. So I think that their data worked out that ACE and ARBs weren't driving it, but if you had some of these other, using these other drugs for other comorbidities, it worked out. And this didn't matter whether you broke it down by gender or age. So there was no elevated risk for COVID-19 with the use of ACE and ARBs. This was also seen in another study, also published in the New England Journal of Medicine, which showed the same thing. They matched patients who had severe COVID-19 and patients treated with medication compared to those not treated with medication. There was little median difference and no statistical difference between using ACE inhibitors, ARBs, or either one, even compared to beta blockers and calcium channel blockers and thiazide diuretics. As you see, the thiazide diuretics, which can be used for hypertension, can also be used for other forms of disease like heart failure, and there was a slightly higher median difference there. So the bottom line is, to date, no association with ACE inhibition or COVID-19 infection or severity, and that's on top of existing hypertension as a comorbidity. So what about hydroxychloroquine usage? And I bring this up even though we're not using hydroxychloroquine anymore, but in the early stages of pandemic, we were using a lot of hydroxychloroquine. We do know that there is no benefit of hydroxychloroquine in COVID-19, although this was controversial at the beginning. And our institution used hydroxychloroquine early on until the data suggested not. This is data published, I believe, in June or July, which looks at the number of events of patients at risk on hydroxychloroquine and no hydroxychloroquine. And you can see on gross data, 32% of patients taking hydroxychloroquine had either intubation or death, compared to 15% off. But when you standardize this through propensity score analysis and look at hazard ratios, there was basically no benefit of taking hydroxychloroquine, even though there was more adverse events. Okay, it had been touted that maybe pre-exposure, this should be pre-exposure hydroxychloroquine to COVID-19, and again, no protection. So these are the outcomes looking at hydroxychloroquine therapy for post-exposure prophylaxis in the United States. And the bottom line is no statistical difference for use, although there was, even though there was more side effects with hydroxychloroquine usage. Now, why do I bring this up? Well, it turns out there is a sodium channel variant that is prominent in African Americans. It's the serine 1103 tyrosine in this NAV 1.5 sodium channel that is present in about 8% of African Americans. They carry this variant. And if you have this variant, if all of a sudden you get hypoxic and have exaggerated immune response, you can go into sudden cardiac death. And you get hypoxia and exaggerated immune response when you get COVID-19. And you can have direct myocardial injury. On top of that, hydroxychloroquine prolongs the QTc interval on your EKG. So that can also trigger this. So this confluence of, if you have this sodium channel variant in African Americans, and you get COVID-19 and get hypoxic, this immune response and direct myocardial injury, and on top of that, you take hydroxychloroquine, you just elevate your risk from this confluence of factors to having sudden cardiac death. Could that have been a driver for some of the excess deaths? Well, I say it's potential because no one's actually studied it. This warning came out from that paper I just showed you on the previous slide, but no one has studied all these deaths and see if people had that variant. Could that be a driver for some of the excess deaths that we've experienced in the Black population? So it's not studied to date, so I can say it's only hypothetical. What about ABO blood group? Okay, so there's data that have come out. This is data that has recently come out, again in the New England Journal of Medicine, looking at GWAS of patients infected with COVID-19. And there are two peaks on this Manhattan plot. One on chromosome 3, which gives you these genes, and one on chromosome 9, which turns out to be the ABO blood group. And when they analyze this ABO blood group, the odds ratio for COVID-19 was 45% higher if you had blood group A, and 35% lower if you had blood group O. Okay, this is pretty impressive. This is the data that just came out in one of the infectious disease journal, which confirmed that. This shows, this is a study out of China, looking at those with blood group A and AB. And if you look at the line, if you're to the right of the line, you're more likely to have COVID-19. And you can see with A alone, 1.2, with AB, 1.4. B group, right on the line, so no difference. And O group seem to be protected, okay, with odds ratio 35% less than standard. Now, could that be driving a racial difference? The answer is probably not, because it turns out African Americans from the Red Cross make up 28% of blood group A compared to 36% for Caucasians, but they make up way more blood group O, 47%, than Caucasians, meaning that it couldn't match or at least cause the disparity that we see. So the bottom line is blood group type A is associated with higher risk of COVID-19, but there does not appear to be an association for a race or ethnic propensity for COVID-19 based on blood group. Okay. What about virulence of the virus itself? Well, this hasn't been really studied, but keep in mind there were data came out of Europe, showed that on the spike S protein, that if you had the S614G version, which was predominantly in Germany and Kuwait, the deaths per million population were much lower than this higher virulence D614G in these other countries where the death rates per million population were much higher, okay? However, this has not been studied, and you'd think once, you know, a certain virulence factor was in a population, that would be the one that would spread. But this has not been studied based on race or ethnicities to date, so I can't comment on it. Now, some of the most fascinating data has come from gender in COVID-19 biology. So first, some epidemiology. This is data out of Europe looking at similar number of cases between males and females. Even though I showed you in New England Journal, females were less likely to get hospitalized. The European data was made it look about even, but I'm sorry, for cases. The hospitalization was higher for males, as others have shown, much higher for ICU cases, and higher for deaths, with one being even between males and females. Thus, the case fatality rate was much higher for males. This didn't matter what age group you were in. So this was higher whether you're less than 50, 50 to 59, or even older, with the expectations coming as they're older because other comorbidities may come into play. So more males than females are being hospitalized, get into the ICU, and die, no matter what age group you are, based on European data. This is data from France, published in Science a few months ago, showing a very similar thing. The probability of getting hospitalized or infected with males in blue, females in the pink, show that the curves are much higher for males. Probability of ICU hospitalization, much higher for males. Probability, no matter what your age, probability of death and hospitalization higher in males. Thus, the overall infection fatality rate was higher in males. Now, data from the US shows exactly the same thing. These are cases by gender or sex. Females were making 52% of the infection. Males were 48%, but males were 53% of the deaths. Okay, so a big differential. And this didn't matter, again, by age group, with women showing standardized 2:1, and whether you're under 44, 45 to 54, 55, 64, etc., males had anywhere from 1 to 2.5 times more likely to die from COVID-19 than females, and that's depicted in this curve as well. So what's the difference between male and females? Well, the obvious difference is the level of androgens, okay? And so this is, I just took this from the internet showing, you know, males have a burst of androgen right around time of birth, and then certainly during the time of puberty. Women make androgens as well, but obviously not as much. And in theory, if this was related to the virus, you would think that if you looked at androgens on the, you know, the x-axis and the SARS-CoV-2 on the y-axis, that anytime you have a hyperandrogenic state, you would have much worse SARS-CoV-2. And so, so if this is the male adult here, kind of on to the middle right of this x-axis, people with acne or polycystic ovarian disease or large prostates or taking external androgens should have a much higher case and perhaps death rate from COVID-19 compared to those who don't have those. But that has not, at least I haven't found anything in the literature that suggests people who are taking anabolic steroids and those type of things have a higher death rate from COVID-19. At least no one has studied it. But there is some biology and truth behind this to date. So we do know that the SARS-CoV-2 virus relies actually not on one, but two main human cell surface factors for infection. I told you about the ACE2, which it binds, but also a second factor called TMPRSS2, which is a serine protease that primes the S spike protein for the virus before it can bind to the ACE2 receptor. It turns out there is some evidence that both ACE2 and certainly TMPRSS2 are antigen responsive for their expression. In particular, TMPRSS2 has an antigen response element in its promoter that is activated by testosterone to increase the expression, which ultimately then primes the spike SARS-CoV-2 protein, binds to the ACE, and increases cell infection. Now, where have we seen TMPRSS2 before? We've seen it in prearrangements with prostate cancer. So what happens in prostate cancer is that there are chromosome rearrangements that puts the antigen responsive TMPRSS2 in pair with a proto-oncogene, most commonly ERG, in prostate cancer to give you antigen-driven prostate cancer. Now, does this explain a gender difference or racial difference? So gender difference, yes. Racial difference, no, because data published earlier shows that the amount of TMPRSS2 and ERK fusion is less in Black Americans compared to white Americans. There are other rearrangement that occurs, but they seem to be less in Blacks compared to whites. Now, what has not been studied is specifically the antigen response element on these. It turns out the antigen response element in the TMPRSS2 is polymorphic. And African Americans have less number of CAG repeats in those antigen response elements compared to Caucasians. That has not been fully studied to date. Also, I will tell you that TMPRSS2 is not only expressed in the prostate, it's also highly expressed in the GI tract, urinary tract, and in particular, the lung. Okay? There have been several studies that showed the coalescence of ACE2 and TMPRSS2 in the lung, as both factors are needed for the SARS-CoV-2 entry to human cells. So here, ACE2 expression is highly expressed in the nasal goblet cells. And I think this is why those nasal swabs pick up the virus very well. And also it appears to be very specific. So based on the size of these dots, getting down to club cells and the type 2 alveolar cell in the lung, okay? Now, in another study that was released in the IMBO journal, they showed high expression of ACE2 in those similar club cells, and they found the highest in what they're calling these secretory 3 cells, which is a transition between a goblet and a ciliate cell. If you look at the coalescence of both ACE2 and TMPRSS2 expression, it seems to be in these secretory cells that they've relabeled, as well as the alveolar type 2 pneumocyte. Now, this is a study that just got published looking at the expression of ACE2 and TMPRSS2 in lung cells. So they looked at the difference between males and females. So there might be some density difference, but the expression levels difference, this particular group, when you take lung tissue from cadavers, they couldn't find any difference in the level of TMPRSS2 expression. And if you broke it down by the types of cells, they also didn't find any significant difference. If you look at ACE2, the expression level was significantly different between males and female, with higher rates on average in males. And this is shown in these bar graphs from that same paper, showing that the significance was more in a type 2 pneumocyte in the male compared to the female, and the coalescence of both TMPRSS2 and ACE2 were highest in the type 2 pneumocyte. So when you put all this together, the virulence of COVID-19 for men might be based on the expression of TMPRSS2 and ACE. So testosterone itself can induce heat shock proteins that activate stress conditions that might drive these sexual dimorphic responses. The subsequent level of TMPRSS2 that is on a cell surface that is activated by the androgen might differ between men and women. Here, men showing more of the expression and women showing less of the expression. Interestingly, for treatment approaches, there are clinically approved TMPRSS2 inhibitors that could theoretically prevent or slow infection, and those are in clinical trials right now. In addition, as alluded to in my hyperandrogen states before, there are some men on androgen deprivation therapy for prostate cancer. And in this particular study, they looked at the estimated cases per 10,000. So if people are androgen deprivation therapy, they should have less, right? And the data supports that. So the rates per 10,000 were 8 per 10,000 on men on androgen deprivation therapy, but 31 per 10,000 on men with prostate cancer who were not on androgen deprivation therapy, suggesting that this theory is likely true. Now, to go full circle, one explanation why health comorbidities are a risk factor for severe COVID-19 is that some of these conditions itself increase the expression of ACE2 and TMPRSS2 in the lung. This is a study among asthma patients. It's noted that males, African Americans, and those with diabetes all had some degree of level of increased expression of either TMPRSS2 or ACE2 or both. And this is collected from sputum cells, okay? So these three groups, because they had asthma, showed increased expression of these virulence factors. I should also point out in this wonderful paper that was just published in the Journal of Infectious Disease, showing that patients with almost any lung condition, lung adenocarcinoma, chronic obstructive pulmonary disease, COPD, had higher levels of ACE2 compared to adjacent normal damaged tissue, a normal tissue that's not damaged in the lung. And going back to previously published data, going at Ava Spiro's data from 2004 on bioinformatic approaches, showing that whether you're a smoker and or had chronic obstructive pulmonary disease, the level of ACE2 expression in data well before we knew about COVID showed that there were much higher levels of expression of ACE2 in 4 different studies that were previously published, and in 3 additional studies for pulmonary hypertension, which could be reflective of either cardiac or pulmonary disease. ACE2 expression was much higher. So it turns out that some of these comorbidities may cause more COVID-19 because then themselves help increase the virulence factors for COVID-19 chances. So the way I think of this now is 2 intersecting circles. We have socioeconomic inequalities in vulnerable populations that can get health comorbidities, severe illness, and sometimes that can be one vicious circle there. But if you enter this circle through the health comorbidities, you can increase, by having those comorbidities, increase ACE2 and TMPRSS2 expression, get increased severe COVID-19 susceptibility, get severe illness or death, which could enter back into the other circle, or then worsen more comorbidities. As we know, COVID-19 has wreaked havoc on kidney disease, myocarditis, and has threw the lid off of the regulation of diabetes. So just kind of to close this out, what are some other potential effects of this disparity? So first, look at out-of-hospital cardiac arrest, okay? So this is data from the New England Journal of Medicine also, showing in kind of the yellow, out-of-hospital cardiac arrest in 2019. And look at the 33% increase in out-of-cardiac hospital deaths in 2020. On the flip side, that was data from Italy. On the flip side, look at California for in-hospital cardiac arrest. So dying from acute MI in 2019, this yellow line, and then in-hospital acute MIs dropped dramatically in 2020 when COVID hit. This suggests to me one of two things, the second being the more likely. Is there less work, travel, and stress, and there's less MIs, but why would we get more out of hospital cardiac arrest? But it's more likely less presentation to the ED. You're getting more out of hospital, out of COVID fear, excuse me, and more out of hospital cardiac arrest and less in-hospital cardiac arrest. And this could be exacerbated in vulnerable populations more acutely than majority populations. Similar data for stroke evaluations. This is looking at the slightly upward trick for stroke evaluations coming to a hospital. I think this is Kaiser Permanente, if I remember right. And then COVID hits, drop, dramatic increase, and you see some rebound. That dramatic decrease is fear of coming to the hospital. It wasn't that the number of strokes nationally dropped, it's because they're just not coming to the hospital. I know personally of some of my colleagues' patients who actually had strokes out of hospital and refused to come to the hospital for 3, 4, 5, sometimes 10 days and had permanent damage. So this is out of fear. But I think COVID-19 may potentially exacerbate and worsen access to acute care for minorities and medically underserved patients and increase that disparity, even though there's not data out there to date to fully examine that. What about some other, what about delay of preventive care? This is data recently published looking at cancer care. All patient encounters, whether you had cancer or were screening for cancer, dropped dramatically by April. New patients dropped dramatically, and screenings, which are preventive, dropped 89% for mammograms in April and 85% for colorectal cancer screenings. Dramatic changes because we shut down our health system. This is a graph I drew that just got accepted in Cancer Prevention and Research that looks at where we would be depending on how we respond to reinitiating screening. So this is the line showing our trajectory for screening in the population. COVID-19 hits, we drop dramatically. And this is the dotted line is the trajectory line that we were on. We could follow line A, which means rapid screening in 6 months, no further shutdowns. Even with that, we will have 10,000 excess deaths based on Ned Sharpless data over 10 years. So that's 1,000 per year. If we have a delayed screening, so it's delayed 1 to 3 years, the number of deaths, excess deaths from no screening jumps up to 1,000 to 5,000 annually. And if we never get back to that trajectory line, that could be even larger. So, and we've already had, it's been taking years to get underrepresented populations to get screening, and we're still not there yet. And this is going to widen the disparity for sure. This is Ned Sharpless data showing just for breast and colorectal cancer, 10,000 excess deaths with a 6-month delay as a conservative analysis. A few other disparities just to close out. Poorest households make up 70%, so food security is going to be a problem. Many of underrepresented and poor people work in the food production industry, and there's been a decline in that. So there's supply chain interruption, loss of income, and don't forget the schools. There are many people who rely on schools for their meals from certain populations. So just to sum up this and close out, one of the biggest drivers is socioeconomic inequities that drives comorbidities and, of course, COVID-19 susceptibility. I think age and health comorbidities are hard to disentangle, but I think health comorbidities keeps coming up because they themselves, many of them, may trigger increased local lung expression of TMPRSS2 and ACE2 to increase the virulence of the virus. Gender, there's an increased potential link to androgen regulation of those same virulence factors. And I think race and ethnicity are tied to the socioeconomic inequities. And although this has not been explored for African Americans, could at least early on some of the deaths been tied to a substitution in a sodium channel in the heart. Other things like blood group type A, ACE inhibitors, and variance factors have either not been studied or they are not a driver of disparities. Disruption in access for acute medical care are potential exacerbation, long-term consequences of disruption of preventive care, and food insecurity. And I'll just add use of video versus phone for telehealth. I mean, a lot of people rely on phone, they don't have computers. That could increase disparity. And also, of course, reversing some of the gains we've made in enrollment for underrepresented minorities in clinical trials. So I'm going to stop there. I'm happy to take any questions depending on time, and so I'll leave that up to Dr. Nguyen and Dr. Tsai.
So we want to thank you, John, for a very thorough review of the literature and a very thoughtful sort of presentation. I think we have time for one quick question, and then because we know that you know, people have places to go, and I know Dr. Carethers, I don't want to keep you forever, but if there's one quick question, I think we can go ahead and ask. Anybody? And I'm looking in the chat line just to make sure. Okay, I do have one.
Sure.
This is in the context of, so you hadn't talked a lot about the vaccine. We have two quick questions. So one is, are you expecting a second wave? And the second is, as we're talking about the vaccine, how will that either change, you know, in the context of your overall, what's the impact on your overall presentation of the oncoming vaccine? So two questions.
So the first one had to do with
second wave.
Okay. Yes, I think there's a second wave because we have not knocked out the virus, and people are getting a little bit more cavalier, and some of our government officials and policymakers are getting cavalier. And the virus is, we're still kind of in the first wave, really. It's not a, it's just it surges in areas. So we do know data recently published that maybe somewhere between 8 and 10% of the US population, based on kidney dialysis data, and that has been extrapolated, have been infected. So that's 30 million people. We have 330 million people. That's a lot more people that are able to be infected. So just to say that the majority of people have not been infected yet. Second, I would say that the surge in the northern part of the United States was in March, April. 4 months later, the surge happened in the South and the West, okay? And 4 months after our surge, which is March, you know, that surge that happened in July, is the November timeframe. We are preparing for a second wave. I don't think it's going to be as bad as what we saw in April, at least in Michigan. But we peaked out about 260, 270 patients in our hospital. Detroit was completely full. I think we're going to see anywhere from 50 to 150. And so we are completely prepared for that. So I think there's going to be second waves in the United States because only less than 10% of the population has been infected. Now, that leads to the second part of the question, what about vaccines? So, you know, there's 120 different places that said they're making a vaccine. There's probably somewhere between 5 and 10 in phase 3 trials. And, you know, one of them's held in the United States, AstraZeneca, because of some transverse myelitis. Some of them are brand new types of vaccines, messenger RNA vaccines, which we've never had a vaccine like that before. Now, if you look at some of the preclinical data on some of those vaccines, some of them offer B cell and T cell protection. Some of them, one particular vaccine in preclinical data in monkeys showed protection for the lung, but the monkey was still spewing virus from the nasal stuff. So, you know, we're going to get a mix of how these vaccines work. Suffice to say, I think in relation to disparities, I think some of the trials are really trying to get a broad representation in a group, some slightly older, diverse populations, and even some young people and how their immune systems work. Others have not done that. So different vaccine trial makers in their studies are limited to 18 years or older, or they're going in certain cities, but others have tried to get diverse populations. I think if we don't nip this in the bud soon, and what I mean by that is getting people back to as routine as possible while we're studying these vaccines, we're going to see another wave of fear
Yeah.
for participating in trials
Yeah.
after gains that we made. So I think it's important to engage communities, use networks that are there, and try to get them involved. I mean, I'll volunteer, depending on the vaccine. I'll volunteer for a clinical trial because I've been reading about them, but I'm not an expert in them. Some of the vaccines out there, like, and I'll just say the one from like Jensen, which I think is owned by Johnson & Johnson, they've used that virus vector in other viruses. So it's probably, there's got a history. The Moderna one, brand new one, who knows? But they got some protection. The Pfizer one, maybe some of their technology was similar to other things they've done. So I think we might be in a situation coming January, February, March, when this is starting to hitting like healthcare workers, that you might take one vaccine, gives you some protection, but you might be taking another one 6 months later because it's better. I mean, so I don't know. That's the best I can answer that question.
I know it's a difficult answer, and again, this is evolving. I want to sort of say again how grateful I am that you took time out of your day to be able to speak with us. I am really been very just grateful for your presentation. Dr. Simon and I decided to do something very different, and so this is the first Grand Rounds that we've actually co-sponsored with the Massey Cancer Center in the Department of Medicine. And so you're inaugural,
I'm honored. I'm honored.
Speaker for that. We hope to, again, at some point have you back and we'll follow up. But thank you so much.
Well, thank you so much. And thank you, Rob and Patricia, for the invitation as well.
Thank you. Have a great day, everybody.